the topic of my talk today is child health ecosyndemics in low and middle income countries. So this is a bit of a roadmap for where I'm hoping to go in this presentation. I thought I would say a little bit just about what are syndemics, what are ecosyndemics, try to make an argument for why I think that child growth faltering in low and middle income countries could be seen as a consequence of ecosyndemic interactions, and provide one example from my work in Peru, and then speak a bit more about some of the biological interactions between infectious disease and undernutrition that can drive these syndemic relationships, and try to say something about maybe the future directions that I'm hoping to take this research as well. So to start off, what are syndemics? This is a concept that emerged in the mid-1990s by the anthropologist Meryl Singer, and I believe that people are probably often most familiar with this concept in the context of the of HIV and tuberculosis, because it's recognized that these two diseases do have this strong biological relationship with one another, and that you can actually drive down the transmission of tuberculosis in a population through the through the provision of ARVs. And so that sense that there are underlying social conditions that may contribute to both diseases, and then this biological interaction which can lead to feedback is what characterizes this syndemic framework. And I guess just to say one additional thing about this, I think that sometimes people conflate syndemics with the broader idea of social determinants of health or disease. And of course, these two concepts are related, but part of the eco or syndemic thinking, to my mind, is getting away a little bit from this kind of bivariate way of thinking about health issues, kind of one exposure and one outcome, towards the recognition that there are interactions occurring. And in addition, we would like the additive impact of these conditions to be greater than additive, so that there's really some sense of interaction occurring. So that's syndemics. And okay, so what are ecosyndemics? This is a kind of extension to the syndemics concept, which was put forward by myself and colleagues 2 years ago now, in which we proposed the idea that ecosyndemics are those syndemics that occur under rapidly changing or unstable environmental conditions. And so the kinds of conditions where I've studied these interactions include new communities that are being affected by new road construction. So very previously quite isolated, and then a road comes in, it leads to lots of population movement, lots of changes in land use, changes in food environments, of course, and so really very quick, rapid turnover. And I'll speak a bit more in a second about looking at this in the context of rapid new community formation, but it's also, you could think, for example, about communities that are affected by anthropogenic climate change, and the COVID-19 pandemic also has been a good illustration of these kind of syndemic concepts, because we've become so familiar with thinking about how COVID can interact with diabetes, for example, or how it can interact with other conditions like HIV. So to study ecosyndemics, for me personally, a lot of this work has rested on longitudinal data collection. Longitudinal because it gives that ability to look at dynamics over time. And I'm also really interested in conducting studies that are multi-level, by which I mean, in this case, trying to work in multiple communities at the same time, and ideally communities that are representing a sort of a gradient in the kinds of changes that they may be they may be exposed to. So this could be, for example, rural-urban gradient, as is the case in Ecuador, or in Peru, newer versus older informal settlements. Obviously, I'm interested in systems thinking, and I'm also hoping that I can kind of do more, have started to work a bit, and hoping to do more in this area of conducting mixed method studies with a citizen science component for primary data collection, so that we can involve populations, both not just in the collection, but also in interpretation of the information that's coming in from their communities. So having gone through that background, why would I argue that child growth faltering is a product of ecosystemic interactions? We know that it's kind of a classic wicked problem in global health because it's seen as relatively intractable. And that's not unexpected given that it is the kind of cumulative product of a large number of interactions that are taking place throughout a child's life. We also understand that going back to our really classic UNICEF framework, that undernutrition, that inadequate dietary intakes, and in fact exposure to infectious diseases are seen as the most proximate determinants of stunting or growth faltering, and that these conditions do tend to interact with each other in a greater than additive fashion. So in this case, looking at the example of mortality, we know that each of these conditions has some contribution to mortality, but it's really the combination of the two, which puts a child at very high risk. So now to give an example of this, which is coming from my work in Peru. So as I mentioned, I like to work along gradients, and this particular gradient was one of informal settlements, all located at the very edge of the city of Iquitos. Iquitos is up here in the Peruvian Amazon, and notable for being the largest city in the world that's not accessible by road. That's kind of the thing people say when they mention Iquitos. It's right, sort of the highest point on the Amazon that you can bring a big boat. And so we worked in 11 communities, the oldest of which were over 50 years old, and the youngest had just been formed in the last year or two. All were informal in the sense that none of these communities, for the most part, people did not legally have title to their land. They had moved into this area, begun to live here, but legalizate, there'd never been that formal legal process. This is what these communities look like when they are very, very new. So for people who know something about informal settlement formation in Latin America, at least, it tends to be this very quick process where people will identify a piece of land, move in an organized fashion, and start to construct houses very quickly. And so we have just maybe something out of tarp on the left, but even in the first weeks, months, people will start to put together houses like the one on the right, which are made out of wood. Zinc roof looks very solidly constructed. And that is because that there is this legal framework in Peru, that there is some level of, there are squatters' rights laws in place. And so if a family can show that they're really living in a place and that they have a house there and they're really solidly rooted in that location, that will give them some legal protection and allow them to stay on the property. So there's a lot of pressure to start building and really developing communities that seem substantial very quickly. But of course, because these communities are brand new, they don't necessarily have access to improved drinking water or sanitation services. And so people are often relying on well water, or in this case, there was a well put into place, sorry, a stream, but also well put into place by the Seventh-day Adventists. So not unexpectedly, given that people are drinking, surface water, you see higher rates of infectious disease or childhood illnesses in these circumstances. So this particular example comes from two communities that I was comparing to one another. Santa Clara, which is the solid line, is a informal settlement that was one of the older ones, so around 50 years old. And La Union was a brand new settlement just formed in the beginning of 2003. The interesting thing in this particular case is that many of the settlers in La Union actually came from Santa Clara. So they were living and they decided to move to this adjacent piece of land. And there was a cohort study that was ongoing, and children were enrolled while they were still living in Santa Clara and then were followed as they moved to La Union. So we were able to kind of see how that sudden transition affected their health. And what we observed is, so higher rates of malaria, higher rates of enteric disease. Interestingly, lower rates of soil transmitted helminth infections, which if you think about it for a second kind of makes sense, because this was a piece of land that previously hadn't been occupied. So there hadn't been time yet for helminths to make their way into the soil and kind of start seeding a cycle of infection. We also see that in these informal settlements, there tend to be weaker relationships, social relationships between households when the communities are very new. That's not entirely unexpected either, because it takes time to get to know your neighbors. But it turns out that this lack of social connectedness is a risk factor for food insecurity, because in this particular context, these social networks are really important as a food insecurity coping strategy. And so even though people may have strong social networks, but those are with family members that are perhaps in the adjacent city, they're not right next door, geographically, available. And so this lack of social support meant that families living in these very new informal settlements were at greater risk of food insecurity, even though they actually scored higher on most measures of socioeconomic status. So their income was a bit higher, their durable assets were often comparable, but their food security was a bit worse. So then you kind of have the perfect storm, right? We have high rates of infectious disease, we have high rates of food insecurity, which are likely affecting child diets. And these two things together result in significantly more growth faltering for children living in these informal, newly formed informal settlements. So going back to the Santa Clara established community and La Union new community example, what we saw is that the children who moved to La Union looked very similar to their neighbors in Santa Clara right at the time that the community was formed. Their height for age Z scores were the same. But after several years living in this informal settlement, they had begun to diverge and were about a quarter of a Z score lower on average than their neighbors. And if you disaggregate this by age, which I haven't shown here, you actually show that almost all of this effect was in the really young children. So children who had moved to the new settlement, either when they were in utero or when they were early infancy. So they were really bearing the brunt of this difference. And so just to kind of conclude this anecdote, we can think about the words of the Peruvian economist Hernando de Soto, who has been was very influential in shaping policy around the formalization of the informal, and putting into promoting some of these laws that now protect informal settlements. And he makes the point that although you might think that this kind of way of accessing land and a home is free, so you're not paying for it, you're really paying in human capital, you're paying with your labor. And I would argue that you're also paying with the human capital of your children, especially the youngest children. So there is some cost to those families. Just to provide a counterpoint though, or maybe a counterexample, these kind of ecosyndemic interactions aren't universal to every community in poverty. So we do see that kind of relationship happening in these newly formed settlements in Peru, but the place where I'm currently working in Ecuador, we operate along a rural-urban gradient, and we actually don't see the same relationships. So we tend to think of our most remote communities on this gradient, which are small rural communities that are not accessible by road. These tend to be the least food insecure. Interestingly, they tend to also have lower rates of enteric disease, pathogen transmission. And the consequence of these two things together is that we actually see less growth faltering in the most remote communities. That's kind of the opposite of what you expect in most rural urban situations. But generally speaking, the prevalence of stunting is a bit lower in the most rural sites and the most isolated sites, although this has been really converging over time. So that gives maybe the broader overview of kind of at a community level what might be going on. So now I'd like to talk a little bit about some of the within individual biological interactions that drive these relationships between undernutrition and infectious disease. And I'm going to focus here on this kind of part of the diagram where you see intestinal damage, nutrient malabsorption, and inflammation. So a good part of my work has been related to trying to better characterize environmental enteric dysfunction through improved biomarkers. Environmental enteric dysfunction is a syndrome of small intestinal villus atrophy and crypt hyperplasia. So villus atrophy, you have these long, nice finger-like villi, such as in the figure A, great for nutrient absorption, and they become atrophied, so they kind of blunt down, and then we have crypt hyperplasia kind of filling in the gaps. And so you begin to see small intestinal surface that looks more like slide B. But obviously we don't wish to do biopsy studies for the most part, especially in young children. It's invasive and also just not really feasible for the most part. So there's a desire to try to understand this condition through biomarkers instead. And unfortunately, the biomarkers that are available to study EED are somewhat limited. And I'd say they're limited to the point where they are really causing a lot of confusion in the field about even what is this condition? Does it really exist? What does it mean? Yes, it exists. We can see it clearly in biopsies. The question is really, how do we measure it through biomarkers? And so some of my work has been looking at the lactulose mannitol test of EED. This is a well-known test of gut leakiness, people would say. And this is what I have here is kind of the classic description of how that test is operating. So we have lactulose, which is a large sugar that theoretically should not be passing from the gut into circulation. And then we have mannitol, a small sugar that should be taken up readily. But if a child or an adult has environmental enteric dysfunction, then there may be leakiness, spaces in the gut for lactulose to permeate, and mannitol might also be taken up more poorly. And so then you have more lactulose, less mannitol, and a higher LM ratio. It's an indicator that there may be an issue. And sure enough, in some of our work looking at how this test performs among young children in low and middle income country settings, we do see that higher LM ratios are associated with asymptomatic pathogen carriage, especially carriage of parasites. And we also see that children who have recently had a symptomatic diarrheal episode tend to have higher LM ratios, and that this falls off a week or two after the episode. I've also worked with colleagues who have tried to understand a bit how EED might be impacting nutrient absorption. So in this figure, we have on the left-hand side, nutrient densities from complementary foods. So measures of nutrient intake. And then on the right-hand side, we have biomarkers of micronutrient status. And so the goal then is to understand what is the relationship between these two things, intake and status, and how might this be mediated by environmental enteric dysfunction, which is everything in the middle, as well as systemic inflammation. And so that we found that yes, indeed, if you have high levels of EED, this is somewhat attenuating the relationship between intake and status, especially iron status. So it may mean that you require that the dietary requirements become a little bit greater so that the child can still basically get the same amount out of what they're eating. And also, I guess maybe another point to make in this figure is that, as you can see, there's been great effort to model a lot of different things at the same time, which is the purpose of this Bayesian network that was developed. Of course, this is really important for dietary analysis of dietary data, because we know that really diets need to be considered holistically, and anything you eat, your iron status might be related, iron intake might be related to your protein intake and your zinc intake and everything else. And so being able to model things in this network framework gives a little bit more, reduces the risk of perhaps making inappropriate, drawing inappropriate conclusions, because you've just kind of selected a single exposure and a single outcome without considering everything else that might be going on. I've also been involved in multiple studies at this point, and many other people have also done studies to try to characterize the relationship between EED and linear growth. And I would say that we found somewhat consistent results even across a large number of different kind of candidate EED biomarkers. So we see these relationships when looking at fecal measures of intestinal inflammation. We see them with the LM test. We see them with alternative tests like the canurine tryptophan ratio. And so although, as I said, I think there are many issues with these biomarkers and still nothing is perfect, there's, I think, sort of accumulating evidence that there are important relationships there that are worthy of really trying to unpack further. So my most recent ongoing work in this area is actually working with another multi-site, multi-country study this one funded by the International Atomic Energy Agency, in which they are trying to use a carbon-13 labeled sucrose breath test to characterize intestinal sucrase activity, so sucrose absorption. And this has been a really interesting activity. So the child in this case is given sucrose with that carbon-13 label, and then the carbon-13 labeled CO2 is measured on the breath. So I've been working with a mathematical modeler in my department to try to understand how this breath test, this breath curve that comes out of the test, how can we relate that a little bit better to intestinal sucrase activity and disaggregate that specific part of the metabolic process from other things that might be going on, such as hepatic metabolism and bicarbonate kinetics. I'm really excited about this approach in general because it moves us towards functional measures of environmental enteric dysfunction, which is something that has been discussed as a need for a long time. It's okay to say that a child has intestinal inflammation or that they have such and such LM test, but we would like to know something really about how is that changing the function, the ability of the small intestine to absorb nutrients, for example, things that really functional outcomes. And so I think this has been an interesting exercise for me. My other ongoing work in this area are kind of big cohort studies in Ecuador, are looking at the microbiome and trying to understand how enteric infection impacts the development of the infant microbiome across a rural-urban gradient. So again, we're working in multiple communities, the most rural being riverine communities without road access, and the most urban being the larger city of Esmeraldas, and are aiming to enroll about 540 children across these 3 sites. This is just give you an example of what this kind of looks like. It's probably more interesting than me just saying it. So there's the city of Esmeraldas, and then one of our more remote communities, which is, I think, the town of Santo Domingo. And we do have a little bit of evidence already, preliminary data showing that there are some differences in the microbiome along this gradient. Although if you look at this graph on the right, you can see that, of course, this isn't all the variation, all of the human variation that exists in the world. But we do see some differences in gut microbiome diversity and some evidence that there are some functional differences in the microbiome of people living along this kind of remoteness gradient as well. This is just a figure to show a little bit about the kind of data that we're collecting in this study. So we collect stool samples, we collect actually blood samples as well. We do weekly diarrheal symptom surveillance, quarterly anthropometry, dietary recalls every 6 months. So a lot of work has been put into trying to figure out not just what is the high resolution data that we need in order to characterize all the different factors that might be important to the development of the gut microbiome in these children, but also how can we do this even in relatively remote study sites, places where we don't have access by road. Everything needs to be done by the community, the study team members who are from those communities and are living there, and it needs to be things that they can handle. And so we've spent a lot of time, for example, thinking about how to collect environmental microbiology in this context. We do that. There are incubators in every town, and people are doing this work themselves. So that's something I'm very interested in, as well as this idea of how can we collect this data at high quality, even in these kind of somewhat resource limited settings. And my other kind of ongoing or future work within this cohort is trying to begin to integrate direct measures of child neurodevelopment. So I've written several grants of varying sizes to try to get this work funded, and have also begun collecting some pilot data. I think that although obviously I think that child growth is really interesting and important, it's obviously not the entire picture or the only outcome that we care about. In fact, it's really only a proxy for something, cognitive development, that we know is so important long-term. And so that's been a big part of my effort for the past year or two, is beginning to think about how we can expand the cohort in this direction, especially as the children begin to grow older. All right, so this, of course, I think everyone who studies like child undernutrition has like used this slide at some point. And I just put this in because, of course, nothing I'm talking about is new, right? Like we've known all of this since the late 60s and 70s and seminal work by Leonardo Mata showing that we know that there is this interaction between nutritional status and diarrheal disease that leads to progressive growth faltering as children get older, and that children often do well for the first few months of life, and then infections occur and they begin to fall off. And then before there's the opportunity for catch-up growth, another infection hits and another. And that's what ultimately one of the important factors that may lead to progressive growth faltering and eventually stunting. So another thing that I've been working on more recently is trying to think about how these dynamics can be reproduced with descriptive models of infant growth. This particular iteration of the model that I have in this slide is really just descriptive one, but it can be, we can use empirical data to try to get it a little bit closer to reality, or at least a little bit closer to what we observe at a population level. And so here on the most left-hand side, we have the growth of a child, sort of a simulated child who is experiencing enteric infections at a fairly low frequency. And so what happens is there are these small infections, they have a temporary transient impact on growth, and then there is sufficient time for catch up. And so the child catches up and manages to return to their previous growth trajectory. In the middle, we have a situation where the frequency of infections has been increased a bit. And so now there is inadequate opportunity for catch up. So infections are occurring and there's just never the time that's necessary to really get back to where that child would ideally wish to be, at least over this first, this 5 years that's being modeled here. And then we have this kind of most extreme case where now infections are so frequent that not only is a child becoming, experiencing some growth faltering, but they're really completely falling off the curve. And this would be a child that we would imagine as being at very high risk of mortality, for instance. So although that model that I just showed is really fairly descriptive, we can still use it in a few interesting ways. One of the ways that it might be helpful is in allowing us to test out some of the hypotheses about what's going on and see if those hypotheses really seem to match to real data or not. And another thing we can do is use it to try to make, to start thinking about how those kind of interactions between slowed growth, but also catch-up growth might then lead to sort of interpretations about what might be going on at a population level. So in this figure, all that's happened is I've simulated a lot of the growth curves that I just previously showed, and then used that to try to say something about what the population that would look like, for example, at 2 years of age. And so you can see on the left-hand side, we have kind of a population that has very little stunting and also a very low burden of infection. So everyone is doing great. And on the right-hand side, we have a population that has a really high burden of infection. And as a result, pretty much, very few children have any opportunity for catch up, and everyone is becoming progressively stunted. And so the interesting kind of thing there is that if you were trying to run your WASH intervention study to understand what is the impact of pathogen, reducing pathogen exposure, how will that affect child growth, operating on either extreme of this curve probably is going to lead to a null result, because you're not really operating in this kind of middle area, this tipping point where interventions would have the potential to have a big impact, because you're really operating at that point where there's just kind of that balance between infection and catch-up growth that you can really push in one direction or the other. So in conclusion, just a little bit about why do I like this ecosyndemic framing for my own research? I find that it's been helpful for me in trying to think about the connection between environments, social conditions, and health outcomes. And that I think it's also somewhat timely, because we know that the world, that there are more and more communities that may be facing these sudden disruptions in the world. And so it gives us the opportunity to try to reflect a bit more on not just what is the impact of an exposure on stunting, but what are the characteristics of a community that could make them somewhat resilient and able to protect their children, given rapid socioecological change, versus what are the characteristics that might make them somewhat vulnerable. And so I'm trying to move my thinking a little bit in that direction. I also, kind of moving along that line, I think it's helpful in trying to reflect on when to intervene. We know there are lots of kinds of disruptions that are predictable, because we know when a road might be built. We know that new informal settlements are being built all the time. And so we can study those, before things happen, during and afterwards. And that might give us some insight into unpredictable disruptions as well. And also, I think it's interesting to me to think about communities also as having their own life course, and that there may be moments when intervention can be particularly timely and particularly helpful, versus other moments where maladaptive strategies may be somewhat crystallized and it may be more difficult to have the same impact. So then something about how to study these things. I think another kind of reason I like this framing is that it, to my mind, encourages collaborations that are multidisciplinary, so that we can bring lots of different heads together to try to study what's going on in maybe one group of communities, and kind of get lots of different perspectives and look at lots of different parts of the elephant. And I find that to be very satisfying. And I think it also promotes a kind of relationship with the community that is hopefully long-term and sustained over time, so that we're able to really not just understand the community well, but also have all those relationships in place that make our work a little bit easier to connect to policymakers, to NGOs that may be operating in the region, and so forth. A lot of the work that I'm doing in Ecuador now is following this brigadista model. This comes out of the vector-borne disease research, and it's also not really novel. It's very similar to like the community health worker approach, but the reason I use the term is because I think it kind of formalizes a lot of things that often go on in research, but maybe aren't necessarily brought to the fore. So what the brigadista model essentially implies that when thinking about data collection, if you have the choice between maybe a very small number of full-time workers and a larger pool of part-time individuals, that you think about that second model, that maybe you're hiring a larger number of people part-time. And then so you're kind of trying to, of course, this depends on the kind of data collection, right? Whether or not it's appropriate, but in cases where it's appropriate, you kind of work with this larger pool of community members, and then you can also hopefully bring them into analysis, or rather interpretation of the data that they've collected. So we've used this pretty successfully for mapping. We've used this successfully for surveillance. And I like it for a few reasons. I think that it's helpful when, again, thinking about how to access difficult to reach locations, which could be like a remote community, but could just be inside of someone's home, right? Working with community members is always really key for that. It's helpful, again, thinking about task shifting and trying to think about how can we collect data that maybe typically would be collected by a professional or a person with more specialized training, but how can we organize, how can we do that work in a way that makes it possible for our community members to do the work themselves, to gain some professional training through participating in that activity, but also allows us to roll it out on a wider scale. And I also like this model because I think it leads very naturally into community mobilization. So if you've collected the data with people, you've been interpreting it with those same kind of pool of community members, then when it comes to the point where you're hoping to conduct a community-based intervention, you've already sort of had this possibility of working with people to try to understand what the best intervention would actually be. And also the community, hopefully by this stage, already has some understanding of what you might be doing and why, and is interested in working with you on that project. So I think I was told that in these kind of talks, you should say something about future directions. And I gave a few examples of maybe grants that I'm actively writing already, but I thought I would just give one more, which is a little bit more general, just to sort of try to share something about where my my head is at. So this is a kind of a version of a very small internal grant that I recently wrote. Not exactly, you know, the same thing, but hopefully it gives sort of some idea of the ideas that I'm kind of circling around for the next stage. So my thought process here was that I was interested in trying to assess the relationship between the food environment and child nutritional status, and that I would do that again through this brigadista model of having a pool of part-time community members collecting the data that could be done through just like a regular Android tablet application, or if money becomes available, scale it up and use like a cell phone application to do that. And then once that data was collected, kind of show the data to the brigadistas as well as other key stakeholders such as food vendors, and use that to initiate discussions about particular community-based intervention strategies that we might want to undertake, also to try to understand just more fundamental things about how people feel about what does a healthy child diet look like, and what kind of things are they interested in promoting. And maybe within those kind of focus group qualitative data collection, do some group-based system dynamics modeling, so very qualitative system dynamics model that allows us to kind of co-develop an understanding of what the key aspects of this system might be, and then pull that into an agent-based model framework to actually do to try to run some simulations to understand what the potential impact of any of these proposed interventions could be. Yeah, so this is obviously not like the only thing I hope to do in the future. And I think it's just an example, but I think it gives some sense of the kind of data collection I'm kind of interested in at the moment, which is this more systems focused data collection of trying to query a lot of different key stakeholders a bit to try to put together these maps of what's happening at a systems level, and continuing with this citizen science approach. So in conclusion, I'd like to say thank you to all my collaborators, people in Peru and in Ecuador, all study participants. And yes, I'll open it up to any questions if there's time.
Yes, no, thanks, Gwyneth, so much. Yeah, I can see Stefan is also applauding. He to me is an early person that actually taught me about, I don't know if he uses the term, but Ecosyndemics. It's what I think is your area too, Stefan. But if let's open up for comments and questions.
Yeah, maybe because I have to go to somewhere else. If it's not unpolite, I would just want to make one comment. So I find this very fascinating and interesting, and obviously in our School of Public Health, and Shona will agree, the concept of syndemics is a daily appreciation. What I feel with a lot of what you say, one of the underlying mechanisms of all these exposures that lead to these problems is poverty. So in my eyes, again, a primarily socioeconomic issue is in your thinking of the conclusions that you want to take now, something like job creation or work with government in terms of support, economic support of populations, because I would say these exposures would go away to a large extent if the economic situation would improve.
Yeah, I agree with you. And I think that is perhaps true. I guess I'm not sure that this actually addresses, like, I think as you said, maybe poverty is really, that is what you just said is the most important thing, right? But one of the things I'm kind of particularly interested in at the moment is this idea of social connectedness and relationships within communities, and how that can really serve as something that, as I mentioned in the kind of Peru example, the poorest communities were actually doing better. Why was that? Partially because they had a really strong, they had everyone, 50 years old, multiple generations of people that had And so that was a useful, I think, strategy. And I also see that a lot in our work with Ecuador, sometimes also networks between communities where a really powerful, these are communities that are, there's relatively small, they have a certain degree of leadership, a small, group of local leaders, right? And those people are actively going to the government, going to NGOs saying like, we need this, we need water system, we need food support, we had a flood, we need help with this and that. And so they talk, when some of the qualitative work we've done, one of the things that comes up a lot is that one of the things they appreciate are projects that link them to other communities and projects that link them to power, because that gives them this connection where then they can go and advocate for themselves more effectively. And so, yes, I think poverty is everything, but I think that also there are ways to try to explore some of these issues of both connectedness within households, but also connectedness within communities that are sort of essentially, giving people access to resources, basically.
Yes, Stefan.
Yeah, I could follow up. More biological. I saw in your Bayesian model that you used neopterin in one of your biomarkers. I know that from the old days treating malaria patients, where we were looking at macrophage activation as an indicator of ongoing infection. Is this meant here as an infection correlate?
Yeah, so that is why it was being used, is it was being proposed as a, so they were trying to get at different aspects of immune function, right? I think neopterin actually turns out to be not a particularly good biomarker, and partially because it's often operating kind of in unexpected ways relative to everything else. Maybe that means it's not really bad. It maybe just means we haven't figured out how to use it properly yet. But that work is a couple years old. And I think now if you look at newer EED work that people are doing, they're often leaving it out because it's just a little bit hard for people to interpret at times.
Thank you.
I don't really do
Arnold.
this, but I will. I'll sort of follow up with this kind of work. But I'll follow up on Stefan's question in terms of the poverty issue. You alluded to, and maybe there's other, I would assume other literature as well, the idea of differences between very remote, very rural versus urban. And I was in Peru many years ago, and I know there's rural poverty and there's tremendous urban poverty as well, and the hills of Lima, et cetera. Are there interesting insights around differences between urban versus rural in the setting of tremendous resource limitation, et cetera, in this growth stunting, if I bring it really back to growth stunting? Is there any literature on that or thoughts around that?
Yeah, I guess my initial thoughts are I've only done some work in these kind of informal urban settlements, but it's something I'm really interested in doing more of in the future, because I do think it's really interesting that people have a tendency to assume that urban is kind of better for child health, and that we don't necessarily see that, right, in impoverished urban settlements. That is so I think that's part of it. I think there's also rural community. Yeah, there's like, as you said, it's kind of complicated. There's access to there's resource access, but there's also certain kinds of, I think part of the reason that rural Peruvian communities and Ecuadorian communities in some cases are doing a bit better than expected is because they have a lot of access to natural resources. And so there's a lot of rural livelihoods going on that's mixed. That's kind of like, there are these like hybrid livelihood strategies that are allowing people to support different resources. And then with environmental change and degradation, that kind of disappears as well. So that's not an answer to your question, but that's kind of
sort of
what it made me think of.
Yeah, no, it's a good answer. It's things to think about in the future.
Thank you very much. That was fascinating. I did have two questions. One thing that struck me is you talked about the ecosystems, and we looked at the food insecurity and the malnutrition, and then you talked about the gut microbiome. Is the cycle you get into between the malnutrition, the GI problems, and then what happens to the gut microbiome, but also the oral microbiome? And does a negative impact on the oral microbiome feed more infection, which affects the gut? I just think they get caught in this cycle. And then if they change their community, it gets totally disrupted again.
Yeah, I'm really curious about that. Yes, I'd love to talk to you more about that. So so for me, I have been just by chance. So I got into this microbiome project a few years ago and I was like, I really need to learn about the microbiome. So I started attending a journal club with someone in my department who studies the oral microbiome. And some of the papers I've been reading recently are making the point that especially for something like stunting, right, the small intestinal microbiome looks completely different than
Right, it is.
it's completely different. And really the small intestinal is probably part of where where the action is, right? In terms of at least like stunting and ED and nutrient absorption, and that actually the oral microbiome is reflects much better the small intestinal microbiome. So I haven't really seen anybody do this. Maybe I just haven't read carefully and found it, but I think you're right. It's really interesting.
I don't know that anybody has, and then what I wonder is the impact of. We know that oral infections, particularly in these undernourished children, can lead to more systemic infection. So if you just have one feeding the other, do we then get more of the other? And then my last question was your future direction slide I was fascinated by, but would you ever consider bringing in a parental cohort to that as well, or caregiver? I don't know if they live with the parent or the grandparent or whoever, but their perception of a healthy diet may be very different than our perception.
Yes. Yeah, no, I think you're absolutely right. I definitely, I agree with you about that. And I think that, yes, it's really important to be actually asking those questions and trying to develop, to try to understand things from the perspective of the caregivers so that, right, so that everything is lining up, and also that any recommendations really make sense for that population as well,
so that you can engage them and empower them to be their own change agents. Thank you. It was fascinating.
Yeah, thank you.
Yeah, Shobha.
Thank you so much. That was a fascinating talk, Dr. Lee. So I'm primarily a clinician. So and your talk was excellent. And my question is, I guess, more towards your future direction with respect to interventions, if you've thought about that. And so what might you focus? Because there's so many different ways you could conceivably intervene, either behavioral, social, economic, or biomedical. Which one would you lean towards intervening, and if so, why?
Yeah, I think that's a good question. And I haven't been involved in intervention studies, and it's something that I kind of have a little bit of feeling like, yes, I need to start doing this now, right? Because I don't want to spend like the next 20 years like doing the observational work and then not making that transition. Although, to be frank, it is somewhat intimidating for a person like me who's only done observational work. So I think what I kind of outlined at the end is probably where I would land for the moment. I think probably trying to think about community-based interventions and trying to, at least for me, just to start off with, having those conversations and then trying to see how that evolves, probably, and leaving it a little bit open-ended.
Sure.
Yeah.
Because interventions can be so many and they can be so challenging, and it varies, the same problem, depending on the context, the community, and the place. It may vary, what works in one community is not going to work in another community, even apparently communities that look very similar. So yeah, thank you.
Maybe Gwyneth, you should consider joining Rutgers Global Health Institute, because we're about making an impact. We could, your platform with the community engagement workers could also lend itself to intervention. But maybe we should wrap up. I apologize for the delay, and we had people that in the comments were very excited about your presentation, and they had to jump off because of the 3 p.m. sort of next appointment. But thank you so much. You'll be talking to some of them at 4 p.m. So, and some folks here. So we can also continue the questions then. Thanks, Shobha, for that great final question from us clinical people. How do we make a difference? And this, you're in a great situation, Gwyneth, with your work to really showcase intervention now too, because again, there's so many factors that come into play as to what's going to be effective. I think what you've shown is that you're going to have to control for those factors to show really what's not efficacious but effective. So thank you all. Thanks for this time, and we'll see some at 4, and we'll continue on. Have a great weekend if we don't see you, but appreciate it, Gwyneth. Fantastic.
Thank you so much.
Thanks.